Hola, hola, hola. How are you guys doing? Oswald, Veronica, Herbert, Marlene, Michael, Claude, welcome. Oh, I forgot this part. Hey, Angela, how are you doing? Did I switch this over from... How was work today? Okay. Nice. All right. Thank you for liking up the live and sharing. Hello, everybody. How are you guys doing? Hola, hola, hola. So I have a few on TT and I have a few on YT. All right. Yeah, so if you see me doing this, it means I'm trying to focus on both of you guys. All right. But how are you guys doing over by YT? So, oh, I never turned on this thing. My microphone so I can be a little bit louder. So tiny. Hi, Jesus, how are you doing? Thank you for joining in. If you haven't subscribed, go ahead and subscribe, follow, my page. All right. And then from there, so we're going to talk a little bit tonight. Well, we're going to go through a few questions as planned. All right. So, and just remember to go ahead and, hit the thumbs up button or double tap the screen, the heart. Yeah. Okay, thank you. Are you a nurse, Jesus? Or are you just passing through? I am Javanese. Welcome. No? Okay. Well, there's something there for you either way. All right. There's something there for you. Random sports stuff. Hola, how are you doing? Thank you for tuning in. Tanisha Paris, welcome. Jav. Christine Flash. Chris the Flash, welcome. How are you doing? Well, go on, Tanisha. Hair salon open tomorrow. I think so. Depending on where you live, you'll have a few hairdressers, you know, around. Okay, thank you for tuning in, Big Bertha. User 800. Okay, nice. So yeah, we're gonna do some questions tonight, but we'll just kind of chit chat for a little bit until a few more persons pop on. All right, I'm doing okay. I'm doing good. Yeah, wasn't a busy day today, so. Oh yes, my name is Stacy. For those persons who are joining in for the first time, all right. I'm a nurse. I worked in Jamaica as a nurse, emergency room nurse. I also I'm to my forehead. I also work as a emergency room nurse here in the States, and I'm doing house call as a nurse practitioner. All right. Thank you for sharing the live, Chris. And thank you for following Nick at Night 320. How are you doing? All right. So how many nurses we have on the live here, if you don't mind? I know, Jesus, you say that you're not a nurse, but that's fine. You know, it still will benefit you. So just hang on there. All right. Bumblebees, welcome. Okay, that's okay. Soon, nice. J is J Jav. Okay, Jav. All right. Soon, not yet. Well, at least you can still get information here. You learn, and that's the most important thing. So just prepare yourself in the meantime. All right. Okay, Angela is a geriatric nurse. What area are you in, Jesus, if you don't mind? Ellen, Isaac, or Isa, welcome. Spam. Okay. All right. Well, thank you so much for tuning in. I'm a nurse, gynae. Okay. I did a little bit of a gynae, but gynae was never my favorite. Yeah. And this is just a girl. Okay. Okay. It's raining. Okay. So I do geriatric now, so no peds. I didn't have a problem with peds, but yeah, just not something I'm willing to do right about now. So that's about it. But thank you so much for tuning in. I feel NCLEX twice though. I'm sorry to hear. You know, sometimes, it's probably just anxiety. All right, there are different reasons why, persons do fail the exam. So don't give up. All right. I've heard about persons doing it 6 times. It's the same thing for their nurse practitioner, program when they're doing the license exam. It's the same thing. You hear they talk about failing it. And some of these persons turn out to be really good nurses. So don't feel disappointed that you fail it twice, Just continue studying. And if it is something that you really want to do, eventually, you will eventually get there. All right. Jesus. I'm in Texas right now. All right. Rowan. All right. So you guys ready for the study? This is going to be the first study session. So we're talking the other night. We're having a wonderful live. So if you haven't, been on one of the lives are usually pretty interactive. So I do post my videos, my long form content on YT. So definitely go over there and watch the entire video in its entirety. We do have persons coming on the live, just sharing their story about transitioning, their experience with orientation, asking a ton of questions, and we're just answering them. And we did a few questions in the end, but then, we said that we're going to do a live stream where we'll just do only questions. All right. So hopefully this will kind of help a few persons. And I know sometimes persons definitely want company. So this is it. All right. You have the extra company today. And if it is something that goes well, then definitely we can try to keep it up on Thursdays or a little bit more frequent, depending on how the reach is. Okay, all right. So, any questions before we start, or you want us to just jump right into it? Just go ahead and top up the live to about let's see if we can go to 2,000 before we start, just to say that we want to do it. All right. All right, bye, Jesus. Not a problem. Not a problem. All right, not a problem. Thank you so much for tuning in, though. All right. Yeah, Santos Portillo. Thank you for tuning in, Yardman 2013. Thank you so much for tuning in, Diamond. Just a girl. Thank you for the live, for liking up the live. Am I missing anyone? I am Javanese. Welcome. All right. So just a girl, just curious. So what are you doing right now? Oh, you say you're in gynae. Okay. Okay. So you're working. So that means you're past the NCLEX now then, man. What's up? Or did I miss it? Yeah, probably. All right, Queen Matt, welcome. Errol Jacket. Hola. All right. So while we're, double tapping and everything, we are gonna go into the meat of the matter for today. All right, so we're gonna start off with a fundamentals question. And as I say, you can always stop in between. We can do a little reading on one and two conditions if we, if we don't know the answer. And then from there, we can move on. All right, Reno. Me no know, Rennie. Me no like your new display picture. I say you call it the icon there. I prefer the other one. That one stand out a little bit more. So yeah, the red, the green, and the gold color. Yes, I did prefer that one. This black and white one, yes, it stand out, but it look a little bit boring. So I prefer your other one. I don't know why you change it. Yes, this one, yeah, but either way, welcome. And if anybody wants to pop up on my screen, to be a part of the live, then definitely you can, send a request and we will do that. All right. So for the first question we have, I don't know how to put it on the screen as yet, so bear with me until I figure out that part. All right. I see some persons doing the stream and you're able to see the question. So I'll work on that. So the first question we have is Watchman Wagwan. Welcome to you. Thank you for tuning in. All right. Deborah Melton. All right, let's go. So the first question, a nurse is caring for a client who is on fall precautions. Which action should the nurse take first? All right, so which action should the nurse take first? And answer A is to keep the bed in the lowest position with the brakes locked. B, encourage the client to call for help before ambulating. C, place a fall risk identification band on the client. And D, keep the call light within the client's reach. All right, so the question says, a nurse is caring for a client who is on fall precautions. Which action should the nurse take first? All right, so A, keep the bed in the lowest position with the brakes locked. B, encourage the client to call for help before ambulating. C, place a fall risk identification band on. And D is to keep the call light within the reach of the patient. Which one do we think is the answer? A, just a girl is saying A. All right, do we have anybody else saying anything else? Angela says A, okay. And if we can get one more answer, that would be nice before we move on. So we can try to see if we can cover at least a lot of questions. It can be C2. All right, so let's go again. So if the patient is on fall precautions, what is the first thing you'd want to do? Keep the bed in the lowest position with brakes on or locked. And the other option is encourage the client to call for help before ambulating. Place a fall risk identification band on the client and keep the call light within the reach of the patient. The answer is actually A. So remember, every time you go into a room or everything you're going to be doing as a nurse, the first thing you're going to do is assess. All right, you're going to use that same thing. Oh, Tracy says A as well. Okay, you're going to assess. So you want to make sure you're keeping the bed in the lowest position with the brakes locked. And then from there, you put the patient in the bed or whatever it is you're going to be doing. Then from there, you move on. Encouraging the client to call for help before ambulating. Yes, you'll tell them about that, but which is the first thing you're going to do? All right. That's not going to really help at that time. Place a fall risk identification ban on the client. You'll put it on, but that's still not gonna, if something is supposed to happen, that's not gonna really prevent the patient from falling. And D, keep the call light within the reach of patient is, it still will help with you coming to the room, but what's the first thing you'd want to do is to put the brakes, lock the brakes on the bed. All right. And that's one thing you always want to do whenever you're going to your patient. Always check to see if the bed is in the lowest position, or you want to check to see if, the brakes on the bed is actually locked. Because once you start moving, then that's a high risk for fall. All right. And so the rationale they have is the priority in fall prevention is ensuring immediate physical safety. A low locked bed minimizes the risk of injury if the client falls. Encouraging calling for help, using ID bands, and ensuring the call light is within reach are important interventions. But safety and immediate risk reduction always comes first. All right. Watchman says A as well. I don't see anybody on YT saying anything, but thank you so much for tuning in. All right. Then let's go to another question. This is a pharmacology question. The nurse is preparing to administer digoxin, and we know what digoxin is, to a patient with heart failure. Which assessment finding should cause the nurse to withhold the medication? And what we know about digoxin? At least one answer. So before we go in, yeah. So digoxin affects the heart rate, and what it does, it lowers your heart rate. It slows your heart rate. So if you see something like this, definitely, okay, just a girl is saying check the apical pulse before. Okay, good. So, if you're preparing to administer digoxin to a patient with heart failure, which assessment finding should the nurse, which assessment finding should cause the nurse to withhold the medication? Respiratory rate of 22 breaths per minute, blood pressure of 138/84, apical pulse of 52, and temperature of 100.2. All right, so the answer is gonna be the apical pulse because the patient is already bradycardic at 52. All right, respiratory rate, it's not gonna affect the respiratory rate, so you don't have to be thinking about that. Blood pressure, it can actually slows the blood pressure, but this blood pressure reading here is actually okay, it's normal. Let's just say 138/84 is a little bit elevated, but we're not really worried about that. The apical pulse is definitely what you want to check before you go ahead and administer that that digoxin. All right. And then after, when you give the digoxin, so for example, the heart rate was 62 when you give the digoxin, you want to go ahead and still check to make sure it's not bradying down too much. All right. So as I say, apical pulse is the correct answer. So digoxin slows conduction through the AV node and can cause bradycardia. The nurse should always check the apical pulse for 1 full minute before administering. If it is less than 60 beats per minute in adults, the medication should be withheld and the provider is notified. The other findings are not contraindications. All right. So if you have anything outside of that, then you should be okay with giving the medication. But once it's the heart rate, you want to make sure you're focusing on that. All right. The nurse is caring for 4 clients. Which client should the nurse seize first? A client who's scheduled for surgery who needs a pre-op teaching. The client who is a COPD who is on oxygen and the oxygen saturation is 88%. A client with type 2 diabetes who requests a snack. Or D, a client with arthritis who is requesting pain medication. Who would you go and see first? All right, so these are your 4 patients. You walk into the room. Which of them you're gonna focus your attention to? The person that is supposed to be going to the operating room, so you're gonna do your teaching. The person who is a COPD, their oxygen saturation is low at 88%. A diabetic who is saying that they want an extra snack or they want a snack, or a client who has arthritis and requesting for pain? Who would you focus your attention on first? And remember, I see you, so even if I'm not able to welcome you in right now, thank you so much for joining in. All right. Just one answer I need. Thank you for the follow, just a girl. All right. And even if you're not a nurse, I'm just picking your brain as well. All right. So you can always just go ahead and choose one answer. And we'll see how, you know, how well you are in terms of your A. Okay, nice. Any other answer? So remember, the first, we have 4 patients. 1 is scheduled for surgery and needs teaching, pre-op teaching. 2 is a COPD whose oxygen saturation is 88%. The type 2 diabetic who's requesting for a snack, and a client with arthritis requesting for pain medication. Who is it that you're going to see first? Going once, going twice. All right, so we have a few persons saying A. Okay, so all of you guys are wrong. Wrong. All right, so the answer is going to be B, the COPD with an oxygen saturation of 88%. Why? The others, they can wait. You understand? The one that is going to surgery, you're just going to do your teaching. All right, so that one is not anything that is life-threatening out of these 4 patients. So you look at you're assessing your 4 patients, who is priority. Always focus on ABC, airway, breathing, circulations. Always go with anything that is going to be like respiratory or anything like that. So based on these patients, B would have been the priority patient, and the fact that the patient's oxygen saturation is at 88%. All right. They normally sat low, but even so, this patient is on oxygen and still sitting at 88. And even so, of the 4 patients, like the others, you know, the one that is requesting pain medication, definitely you'll want to go and address. So that would have been the second option for me. All right, type 2 diabetic, requesting for snack, everything else is good. And the one that is scheduled for surgery, there's no rush on that. All right, so I would go with B, then C. The rationale says here, this is a priority question. A COPD, a patient with low oxygen saturation, is experiencing impaired gaseous exchange, which is a threat to life and requires immediate intervention. The other needs are important, but not life-threatening. So always just go ahead and, you know, choose the one that is, you're thinking about who is going to die first. Who is going to, the prognosis on them is just looking poor. So always go with those persons first, all right? And so as I said, the answer is going to be B, the COPD with 88%. Hola, welcome. Not a problem, Stacy. All right, not a problem. Which of the following patients requires airborne precautions? All right, and we know what airborne precaution is. That's when you remember COVID? Yeah, man. All of that you see, that's what we're doing. All right, so which of the patient requires airborne precaution? Is it the patient with pertussis, the patient who has varicella or chickenpox, and pertussis is the whooping cough, the MRSA wound infection, or the person with influenza or flu? All right, who requires airborne precaution here? I wanted to get something else. Hold on. Varicella? No. Why are you thinking varicella? Okay. So flu. All right. Remember airborne precaution. Remember, every day we walk around patients who have flu. So, and nobody is wearing any form of airborne, like, you know, any form of airborne precaution, like PPEs. So, when you're thinking about airborne precaution, you're thinking about like your COVID, definitely your tuberculosis, all of those conditions, Definitely. Okay. Yes. Yes. So chicken pox is more, well, chicken pox is more, it can be contact and droplet, I think is droplet. I don't think it is, let's double check. Um, Let me try and find out. All right, so contact precautions. You definitely do contact precautions for like your MRSA, diarrhea, C. diff, herpes, all of those. Head lice, scabies, E. coli. Droplet is gonna be for, oh, they have droplet here for pertussis, and some persons interchange droplet and airborne at this with the same precautions like the PPEs. So you have pertussis, influenza, MRSA, bacterial meningitis or mumps, rubella, strep group A, rhinovirus. Airborne they have with the, okay, so yes, airborne they have with measles, varicella. But I think the varicella, it has to be open. All right, so if they just have the regular, if the little pustules are closed, I don't think it is airborne until it is open, when it's popped. All right, and then you have airborne, they still have the tuberculosis, contact is SARS. So I guess this is a little bit confusing. But anyways, it's between both, you know, the droplet and the airborne. The answer they have here is, the varicella. Okay, so they have the varicella as the airborne. So airborne precautions are used for MTV, measles, TB, varicella. You're correct, just a girl. I'll make do the thing on the, you hear the people scream. Yeah, I'll figure that one out. Pertussis and influenza require droplet precautions, while MRSA requires contact precautions. All right, but when in doubt, just come up on yourself. All right, just come up on yourself and carry on. Any just study. All right, so let's move on to, and thank you so much for tuning in, Naz. All right, yes, it is an NCLEX study session. All right, Ella, welcome. So a newborn has blood glucose level of 35. Which action should the nurse take first? Notify the healthcare provider, recheck the glucose in 30 minutes, feed the newborn with breast milk or formula, and D, initiate IV glucose infusion. So you have a newborn who has a glucose of 35. What's the first action you're going to be doing? Notify the healthcare provider, recheck the glucose in 30 minutes, feed the newborn with breast milk or formula, or initiate IV glucose infusion. Notify the doctor. Okay. Let's get one more answer. So notify the doctor, recheck the glucose in 30, feed the newborn with breast milk or formula, or initiate an IV infusion. So do the IV, notify the doctor. Those are what I'm seeing. So what about putting the baby on the mama's breast? Why we don't think about feeding? We want to feed the child? Because if you notify the doctor, you're going to still have that wait time, because the doctor is going to tell you, they're going to give you instructions. So during that time, the child is still going to be hypoglycemic. So while you're waiting on the doctor to give you an order, the child is still hypoglycemic. So first try with the breast milk. Put the baby on, because remember, this baby just pop out, you know? Baby just pop out. So we just have to feed the baby to make sure that glucose goes up. All right. So notifying the doctor is something you're definitely going to do. But first thing, just put the baby on the breast and try to start, you know, get that breast pumping. So for mild hypoglycemia, the first line is feeding to increase glucose. If severe or if oral feeding is not possible, then you definitely go for the IV. All right, the provider should be notified, but immediate treatment is priority. So you definitely want to do, so whenever you answer the question, what is it that you're going to do? No. All right. So the patient is coding. Yes, we're going to tell the doctor, but what can we do in the meantime while we're standing there with the patient? All right. Yes, Naz, thank you for that. You do one-on-one because I think studying with someone else will help. Definitely, we can arrange for that. We can definitely arrange for that. As I said, this is the first time I'm doing the, the class like this. But I wanted to do it on my YT page because I know a lot of persons want to study and they just need a little company. Yeah, man. So I was planning on doing something like this, but sometimes you just need the extra push. And I think the other evening, someone pushed me a little bit, so we decided that okay, we're gonna do tonight. But you can inbox me, we can talk about it. But definitely I'll be trying to keep up with at least doing one session or more, depending on the reach. All right. Nurse Yems, welcome. Thank you for the heart. All right. So let's move on to another question. A client at high risk for falls is confused and tries to get out of bed. All right. What is the priority action here? So the patient is confused, but the patient is a high risk patient. Patient is at risk for fall. All right. What is going to be your priority action here? So remember, when you go in the room, you see the patient, the bed is all the way up here. The patient is confused. What is it that you're going to do? You're going to put the bed in the lowest position. All right. So you're going to always start out with those things. Try and calm her. Okay. Definitely you'll do that as well, Damiel. All right. So 1, apply a vest restraint is A. B, place the bed in the lowest position with the brakes locked. C, move the client near the nurse's station. D is to turn on a bed alarm. So remember, the patient is at high risk for fall, is confused and tries to get out of the bed. What is priority action? Apply a vest restraint, place the bed in the lowest position with brakes locked, move the client near the nurse's station, or turn the bed alarm on. Which one would you think is priority there? A, B, C, D. Yeah, just throw out a letter. Let's see. B, then D. Okay. 1 and 2. Okay. One more. Just one more. One more. Anybody on YT want to answer? Okay. All right, so the correct answer is going to be B. All right, B is the one where you're going to place the bed in the lowest position with the brakes lock. All right, so that's what you're going to do first. Then from there, you can always decide what you're going to do, whether or not you're going to move a patient to the nurse's station, things like that. So applying the vest restraint, anytime you see anything with restraint, a problem. All right. So if you can avoid restraint try and avoid it at all costs. There's too much legalities when it comes on to, restraints. You don't want anything to happen to a patient and you put them in restraint and, so for example, they die. So always try and save restraints for last, all right? So there are things you can do. You place the bed in the lowest position, you lock it. You can think about moving the patient to the nurse's station if they continuously coming out of the bed, you understand, before you even think about applying medical restraint. You can also turn on the bed alarm. So every time the patient moves, decide to step out of the bed, then definitely the alarm goes off. But sometimes that can be very annoying. So if you can get them closer to the nurse's station, less stress for you, you can always be peeping over or, keep the door open. So find things that are, not that that much aggressive, in terms of, or less restrictive, for the patient. So that way in the event something happens, it's not that bad. So always start with the simplest things. And as I say, always just observe your environment and see what you can do to accommodate the change for that patient. All right. So immediate risk reduction comes first. Lock, low bed reduces injury risk. No. Alarm and proximity helps, but are secondary. Restraints are always last resort. All right. Hi, Jesus. Welcome back. Okay. Then, before giving metoprolol, which assessment requires holding the medication? And if we know what metoprolol is, then we know definitely what we're looking for. All right. And what is metoprolol? And anything that has to do with, yes, that's so true. All right. Anything that has to do with LOL. All right. That's a class of drugs. So you're thinking about your beta blockers. All right. Your beta blockers. All right. So anything that has to do with LOL most of the time causes what? Tend to cause bradycardia. All right. Lowers your glucose and all of those things. So definitely you want to make sure you're looking out for your blood pressure. All right. So if you have a patient that is on a metoprolol, you want to look at the heart rate and the blood pressure. So before giving metoprolol, which assessment requires holding the medication? Blood pressure of 150/88. That is elevated. So we'll just go ahead and give the blood pressure medication. Heart rate of 54, that's bradycardic. So you'd be like, okay, let's put a question mark beside that one. Temperature of 100.5, it's not going to affect the temperature, so we'll still go ahead and give it to that patient. Respiratory rate of 20, it's not going to cause anything regarding that, so you'll just go ahead and give your metoprolol. So the two you'd be concerned is with the blood pressure and the heart rate, but of the two, the heart rate is the one that is most concerning because it's bradycardic, and metoprolol is going to further drop your blood pressure as well as your heart rate and cause the patient to be further bradycardic, then possibly become symptomatic and give you more problem as a nurse to do. All right. So just think of it like that. Beta blockers lowers your heart rate, so you withhold it for anything that is less than 60 and you notify your provider. All right. A COPD client is short of breath with an oxygen saturation of 88 on room air. What is the first action you'll take as a nurse? All right. And as I say, even though you're going to be taking the exam as a student, or not really a student, because you'd have, upgraded and gotten your bachelor's and done with that, and you're going to sit your exam, even though you're not working as a nurse, you're expected to answer the questions as if you're the nurse. All right. You already have your RN and you're standing over the patient and the patient is there. You need to take care of the patient. So what is the first action you'll do for this patient who has COPD and the patient is short of breath with an oxygen saturation of 88%? Are you going to increase the patient's fluid, place the patient in high Fowler's position, obtain an ABG, the arterial blood gas, or you're going to start incentive spirometer? Which of them is the you're going to be doing for the patient? So you're there, you realize that this patient is short of breath, you do the oxygen saturation, it's low, 88%. What is it that you're going to be doing for this patient? Patient is lying down, patient is sitting up, patient looks uncomfortable, can't catch them breath. What is it that you're going to do for the patient based on these four things? So the patient has IV fluid. Are you going to be turning up that IV fluid and further overload the patient and cause the patient to get, worsening shortness of breath? Are you going to place the patient in a high Fowler's position to sit up, to have the lungs expand a little bit more, breathe a little bit better? Are you going to be obtaining ABG while the patient is there trying to gasp for breath and the patient is dying and the ABGs are going to come back worse? Or are you going to start the incentive spirometry on that patient? Which would you say? The high Fowler's position, yes, Bliss. Okay. Do we have any other here? I'm really wondering if I'm ready for nursing school because of the fact that people lives in my hands versus x-ray just in and out. Really not sure if I should do it or not. Definitely go ahead and do it. A lot of persons, they're thinking about it. As long as you love it, I would say just go ahead and do it. After a while you start learning, you will eventually get it. You understand? You'll eventually get it. So I would say just go there and put your mind to it and just give it your best shot. You have some persons who are not made for nursing and eventually they go in the profession and they're the best, the best nurse out there. So it's a learning phase you'll be going through, and as you you know, you gain your skills, your knowledge, you become competent. And one thing you're not going to want to do is make any patient dead by you. So if it is something that you really want to do, just go out there and do it. All right. So definitely just a girl. High Fowler's position is what you're going to put the patient in based on what is going on here, because as I said, that is going to help with the ventilation. All right, ABGs and everything else. Yes, you'll get your ABGs to see how, you know, bad it is in terms of their CO2 and all. You want to look at the IV fluid. I want to really turn up the IV fluid. All right, IV fluid. Yes, they probably get some IV fluid, but that's not priority. All right. But the ABG's incentive, spirometry, eventually, you know, they can probably do that, but that's about it. The high Fowler's position based on these 4 answers are the most important. All right. Which client do you see first? A post-op patient, day 2 with pain of 7 out of 10. A new onset slurred speech and facial droop. An asthmatic patient requesting for PRN or as needed albuterol before ambulating. Or a diabetic patient asking for diet. Definitely, Naz, definitely. All right, so which of the 4 patients you're going to be seeing first? You're going into for your shift and you see these 4 patients. One patient is a post-op patient who is complaining of pain, 7 out of 10. There's another patient who is new onset slurred speech and facial droop. Asthmatic patient who is asking for some albuterol just before walking. And then you have a diabetic patient who needs a little bit more food. So we say BB. Okay. Can we get one more answer? One more. Just one. I see 16 persons up there. Just one. All right. Okay. And Maxam says B. The answer is definitely B, because why? What we're thinking about. Marvin says D. Okay. All right. We're thinking about stroke. So all of these 4 patients, yes, they're important or priority, but who is, you know, has life-threatening or is critical amongst these patients? Yes, the pain, you definitely want to address the pain, but if you're going to see somebody that is having slurred speech, drooping, you know, you definitely want to address that patient, because we always say brain, heart is, what do they call it? Brain, time is brain, and heart is, heart is time, or something like that. You know what I'm talking about. If there is any deficits or anything, sometimes it cannot be reversed. You understand? So you want to make sure you catch that stroke from early. So if you notice there is any slurred speech, facial drooping, blurry vision, you know, the blood pressure is super high, whatever it is, address that patient first. Because the patient who is post-op day 2 on pain, having pain, yeah, you're going to be having pain, but they can wait a little bit. They're not going to die from the pain. The diabetic who is asking for, you know, extra diet is still not going to die from any, you know, anything. They already have a lot of sugar on board, but what if they're hypoglycemic? If they are symptomatic and they're having their little slurs, sweating, you know, definitely, if you had 2 of them, but the question never really asked about, never made mention of that diabetic sweating or seem as though they're hypoglycemic. They're probably just hungry. You understand? And the asthmatic patient is not, you know, short of breath and can't, like literally cannot catch them breath. That patient is asking for as needed albuterol. So because the patient know that whenever I exert myself, I tend to feel a little bit short of breath, I need an extra albuterol inhaler before I do that. That patient can just sit quiet for a little bit and you deal with the stroke patient. Then you come back to that patient and then you can send that patient on the merry way to ambulate. All right. So definitely just think about those, because as I say, the stroke is going to be very time sensitive. So you want to address that one. And always remember, ABC, neuro, always comes first. All right. Then let's get on to this one, which is the fetal monitoring. It's an OB case. A laboring client shows late decelerations. What is the priority for the patient here? Which patient is priority? All right. Or what is the priority for this patient? Increase oxytocin, reposition to left lateral, start pushing, obtaining sterile vaginal exam. So it's because I'm an OB nurse. I have to go pull up something here. So, all right. Unless somebody else knows it, but a laboring client shows late deceleration. what's priority here for this patient. So what we need to find out first is deceleration in OB. All right, so we have to figure out what is. So if you don't know the so decelerations. Okay, so deceleration, let's just kind of understand this one. Deceleration is bad, okay. Bliss says don't know, me in the same boat. Just a girl says repeat, early is good. All right, so understanding deceleration. Fetal heart rate decelerations are temporary, but significant decreases in a baby's heart rate observed during pregnancy and the labor. These decelerations are classified into early, late, and prolonged. So early deceleration occurs with the onset of uterine contractions and mirror the contraction shape. The late one begin after uterine contraction has peaked and may even start after contraction has ended. And then they have variable prolonged. Prolonged lasts more than 2 minutes, but less than 10 minutes. And then they have variable, which is abrupt, jagged dips in the fetal heart rate. All right, I think we kind of get the picture here. There is a mnemonic called veal chop. Okay, Tajiri, thank you for that one. Let me see, veal chop. You're an OB nurse, Tajiri? So veal chop. Wouldn't want oxytocin because that would actually slows it down more. Okay, nice. Thank you so much for tuning in. All right. So veal chop says, so veal is the fetal heart rate pattern. So V, variable deceleration, E, early deceleration, A, acceleration, late deceleration is the L. And the cause, okay, so for variable deceleration, I don't know if you're able to see. Oh, it turned back way, sorry. Oh. But for V, variable deceleration, the cause is going to be a C. So what she was saying is the mnemonic veal, the cause is going to be chop, and the management is going to be mine. All right. So I know it's, not correct, but you get the picture, right? So these are the fetal heart pattern, heart rate. These are the cause. So for variable, this is the cause, which is cord compression, and the management of that one is maternal repositioning. All right, so if you have a patient who has cord compression, or the child has cord compression going on, then you want to reposition the mother. Early deceleration, usually it's the head that is compressing, and what you want to do is identify the labor progress. A is acceleration, and it says it's okay. You don't need to do any intervention based on the mine, N. And L, late deceleration, is placental insufficiency, and how you manage that is that you execute interventions. All right, so this seems big. Let's go back to this question now. So the question says, for this OB1, where is it? So what would you do? So in a laboring client with late deceleration, what is priority? It's going to be to reposition to the left lateral. All right. Yes, it has. Yes, it has. So you're going to reposition to left lateral. A, where it says increase oxytocin, you want to do that. C, start pushing, you wouldn't do that. And then D, obtain a sterile vaginal exam, you wouldn't do. So you want to go ahead and do B, which is reposition to the left lateral, because in late deceleration, there is some insufficiency going on. So you want to reposition, give your oxygen, start an IV, get some fluids. And if they have oxytocin going, you want to stop that. All right. Because the placenta is already insufficient with, the blood and everything going there. So you don't want to worsen that by giving the oxytocin. All right. Okay. Then let's go on to immunization, which is contraindicated today for a patient that comes in to see you. 4 patients, MMR in a 12-month-old with cold or mild cold symptoms, DTaP in a 2-month-old, C is going to be varicella in a child on high-dose steroids, and D is hepatitis B in a newborn. Which of them is contraindicated? MMR in a 12-month-old with mild cold symptoms. A lot of times we tend to see patients going in, or children going in, everybody have, cold-like symptoms, and sometimes if they're not having any fever or anything, we just go ahead and still give them their, their immunization. DTaP in a 2-month-old, they never give anything else with that. Varicella in a child on high-dose steroids. Why is that child on high-dose steroids? That is going to be like a red flag. So you want to find out why that child is getting, and just remember that varicella is going to be a live vaccine. So you don't want to be giving a live vaccine to anybody who is possibly immunosuppressant, all right, or immunocompromised, let's just say. Because why is that child on a high-dose steroid? We're not so sure because the answer never really give it, but both of them, it's contraindicated in there, all right. Hepatitis B in a newborn. All right, so we're going to go with C, which is the varicella in the child high on steroids. All right, and just remember that live vaccines such as the MMR, your varicella, are contraindicated with significant immunosuppression. Yes, Bliss, that's it. Definitely. All right. Then which statement from a depressed client is most concerning? Someone tells you, I don't feel hungry. I'm such a burden. I gave my guitar to my cousin. I'm sleeping a lot lately. Which of those 4, it sounds very, very simple, but which of those 4 is something that you would be concerned about for any of your patients, the 4 patients that you have in this perfect world? Which of these 4 patients is concerning for you? I don't feel hungry. I am such a burden. I gave my guitar to my cousin. I'm sleeping a lot lately. And as I said, the patient is depressed. Giving away the guitar. Okay. See, another one says giving away the guitar. Just the girl says that. I'm such a burden. Naz is saying I'm such a burden. Okay. Okay, you're thinking suicidal. Okay. Sometimes when they have a side, they're planning. Okay, definitely correct, Bliss. All right. So definitely see the one that says, I gave my guitar to my cousin. All right, giving away any form of possession is like, because they're having plans. All right, so they start giving away things from early. So giving away possessions equals to potential suicide planning. So you want to make sure you assess your patient carefully for any suicidal ideations. All right. So definitely, I don't feel hungry. Could be a case in just full. All right. I'm such a burden. You can also, keep that one close by because you don't know what else. If you kind of just ask more questions, then you'll be able to identify if there's something else going on. But the one that says, I gave my guitar to my cousin, and I'm sleeping a lot lately. Most depressed people are always asleep. So definitely the one in C is the one that is most concerning. Then I would say B. I don't know if we have anybody else who would say anything else. All right. Which disease requires airborne precautions? I think we did this one already. The measles, TB, varicella. Yeah. That I was thinking it was pertussis. All right, DKA client, which order do you go in first? So for example, you have this patient who has DKA, diabetes ketoacidosis. Which is the order you would go with first for this patient? A is to start an IV of regular insulin for, infusion. You do the IV fluid, which is a 0.9 normal saline bolus. You do the potassium chloride IV, or you do the obtain the urine for ketones. Which of those would you do first for this patient? You identify that patient is in DKA, or diabetes, okay, ketoacidosis, yes, you go with the IV fluid. All right. Treat the dehydration first, okay. Anything else? So IV regular insulin, IV fluid, potassium obtained. So all of those are things you're going to be doing for your patient. But if you have a patient coming in, you want to go ahead and start push some fluids. Go ahead and start hydrating, get some of that ketone out. Start making that patient pee, you know, get that glucose out of that patient. Then you will go ahead and do all the other things. So your 0.9 normal saline, they're going to get a lot of fluids. They're going to get a lot of fluids. You're going to do your regular insulin infusion, all right? You definitely want to go ahead and get your urine as well. And you also want to, most importantly, look at their potassium, all right? You want to make sure you're looking at their potassium before you start that IV insulin. Let me get that wrong. I was saying ketones. Okay. Regular insulin, Naz is saying, yes, Naz. But the answer, what is it that you're going to do first? You know, remember, you're there with the patient. What is it that you're going to do? No, you see the patient and you recognize that based on the lab values, this patient is in DKA. You're going to have to find somebody now to go ahead and countersign your regular insulin, you know, check and push out, you know, the extra air and all of those things out of the insulin, get the orders going. So definitely you want to start with the fluids. You get your fluids and you just attach your bags and start run that in. You understand? Get your fluids going, because more than likely this patient probably going to end up getting 3 liters, a ton of fluids. So when you start running in your, you know, your normal saline, you're starting the process of getting that fluid going, you know, the glucose out, getting that patient to start pee a little bit more before we start all of that insulin. My blood pressure is high, drinking a lot of water. Is high, drinking a lot of water. Huh? Okay. I don't really understand, Angelo. All right. You could tell I'm not in nursing school. No, you are fine. You've been answering a few questions. As I say, you just have to think of it that you're at the bedside. And even if you're not in nursing school, you've been answering some of the questions correctly in a sense. It's just that you're not thinking as a nurse that is at the bedside with this patient. All right. So don't feel disappointed. All right. So as I say, you definitely want to go with the fluids, and then you will get your insulin orders. You know, make sure you're doing your hourly glucose check. You're also going to look at your potassium as well, because you don't want to be giving this thing to a patient and the patient is hypokalemic, and then you further, you know, lower their potassium level. And you also want to check your ketones as well. And then based on the DKA protocol, you go ahead and you replace the fluids, your insulin, all of those things. All right. So fluid resuscitation in DKA is very important. Then you go with your insulin, potassium guided by labs. All right. So you always, is either it's low, you're going to replace it, or if it is borderline, you still replace it and start your, you know, your insulin. But you don't want to be starting your insulin and you don't know what your potassium is. All right. Warfarin teaching, and that's a blood thinner. Warfarin teaching is effective if the client states, A, I'll eat more spinach to keep my energy up. B, I'll report black stools to my provider. C, ibuprofen is best for headaches. D, I don't need INR checks if I feel fine. All right. Which of those, if you have a patient on warfarin and you've educated the patient and the patient come to you and say, either of the 4, which one of them would have said that you've been a really, really good teacher? You've been excellent. The patient has gotten, you know, the education regarding this medication. And when you send the patient home, you know that this patient is going to call you if this is happening. All right. Which of them is correct here? I'll eat more spinach to keep my energy up. I'll report black stools to my provider. Ibuprofen is best for headaches. I don't need INR checks if I feel fine. Which of those says that you're a good teacher or you're a good nurse? B, okay. I'll report black stools to my provider. Okay. Do we have anything else? Anyone else with another? Just the girl says B, yes. All right. So definitely you wanna, if the patient comes and say, I'll report black stools to my provider, then definitely, you know, teaching has been effective because you're thinking about the fact that the patient has GI bleed going on. All of that acid is now mixed with that blood, causing, you know, the stool to be looking black. Remember, the patient is on blood thinner. So you always want to find out if they are pooping any black stool, if they're, you know, vomiting any blood. Sometimes they can be having, you know, bleeding in the gum. If they're bleeding, so for example, they get a cut and they're bleeding excessively, things like that, you want to tell them, report it to you. All right, so the GI bleed is going to be very important when you're monitoring, when you're educating these patients. All right. Avoiding NSAIDs is another one because, you know, NSAIDs, what is going to happen with that is going to cause, you know, bleeding as well. So you want to encourage them to avoid, you know, the NSAIDs. So your ibuprofen, Aleve, all of those, avoid it. Then no, you want to ensure that they're getting their INR checks regularly. All right, so you can know where their baseline is. So we're not kind of making them either bleeding too much. You don't want the INR to be too high. So definitely, okay, antiplatelet, yes. All right, and then consistent vitamin K intake is going to be very important as well. All right, because you don't want them to be like their blood is too watery. So definitely you want them to be, I think it was what, 1.5 to like 2.5 thereabouts, depending on, you know, sometimes if they have like heart problems, depending on what they're taking it for, then they have their different, you know, guidelines for that. All right, so nurses report. Okay, yes, definitely Naz, report the black stool to the provider. All right. 4 hours postpartum, the fundus is boggy and above the umbilicus. What is the first action you're going to be doing? So the patient has just had their baby, and when you look at the tummy, it's still boggy and it's above the umbilicus, like, you know, your navel. It's above there. What is the first thing you're going to be doing for this patient who is in postpartum? Massage. Yes, you're going to massage. So A is called the provider. B is to start oxytocin. C is to massage the fundus. Or D is to check the blood pressure. Okay, Bliss says massage as well. Definitely. So you want to go ahead and do your uterine massage, all right, just to make sure that, you know, you're not having any form of excessive bleeding. Hemorrhage is not going to be taking place. So after delivery, that is something that you normally see, like, you know, the midwives be doing, massaging that abdomen to get it. Vital signs, bless her soul. Yes, definitely you're going to check your vital signs. But at that time, you know, you're not going to be, well, you're going to be focused on the blood pressure as well, because if they're hypotensive, which is going to be because of the fact that you're not massaging that, you know, uterine, that, you know, the abdomen there, because you're not massaging it, then you're going to realize that the patient is going to be hypotensive because the patient is bleeding out. So definitely you want to check the blood pressure. But if you are able to massage the abdomen, get that uterus, you know, back from that boggy state, then you're going to cause the contraction. So the blood flow out is not going to be that excessive. So you won't even have to be thinking about the patient going hypotensive, like, you know, shock. So things like that you want to focus on. Hi, Paul. Good night. Good night. How are you doing? So uterine massage treats atony immediately to reduce hemorrhage. All right. As I say, I'm not really a OB nurse, but Bliss is here helping me out. So just in case. All right. Is Bliss? Yeah. Bliss and Sashay and all the other folks who have been participating. All right. And thank you guys for tuning in. All right. Which findings suggest hypokalemia? All right. Tall peaked T waves. B, muscle weakness and ileus. C, hyperactive reflexes and tetany. And flushed skin and thirst. Which of those suggest hypokalemia, which is low potassium? Tall peak, T wave, muscle weakness and ileus, hyperactive reflexes and tetany, flushed skin and thirst. A, B, C, D. So T waves. So hyperkalemia would give you the peak T waves. So hypo is gonna be, so the hyperactive reflexes and tetany. That's so the low potassium is gonna cause the hyperactive, is gonna cause the weakness and the ileus. It's gonna cause the inverted T wave. It's gonna cause ileus, and it's also gonna cause cramping. So muscle weakness and ileus. Hold on there. So B, muscle weakness and ileus. Am I saying this correctly? So the tall peak T waves are going to be for hyperkalemia, cramping. So cramping is going to be 1. Weakness is going to be 1. Ileus, flat inverted T waves. All right. Yes, blessed soul. All right. Which action breaks sterility? Is it A, keeping hands above the waist? You're doing a dressing. Which of these are going to break, sterility in the field there? Keeping your hands above the waist, turning your back on the sterile field, opening the distal flap first, or holding sterile objects within 1 inch of the edge. Which of those is going to cause you to contaminate the field? Keeping your hands above the waist, turning your back on the sterile field, opening the distal flap first, or holding sterile objects within 1 inch. Turning your back on the sterile field, yes. That's one thing they always tell us. Don't turn your back on your sterile field. When you're doing a dressing, it's the same thing. So yes, so never turn your back on the on your sterile field. All right, and also edges 1 inch are contaminated. All right. So the answer here is gonna be B, turning your back on the sterile field. Never turn your back on that. All right. Let's go on to this one. Head injury client becomes restless with decreasing level of consciousness. What is the first action you're going to be taking for this patient? Reorient the client. A, B, assess the pupils and the vital signs. C, give PRN lorazepam, or D, dim the lights. So you're going to reorient the client. So remember, this patient is restless and has decreasing level of consciousness. So are you going to reorient the patient? Are you going to assess the pupil and the vital signs? Are you going to give PRN lorazepam, or are you going to dim the lights? So Bliss is saying B. Okay. Sachet says B. Nice. Okay. Anyone else? One more. All right. So it's definitely B. Assess the pupils. Yes, blessed soul. Assess the pupils and the vital signs. All right. So you want to check to make sure that there is not any worsening, any increased intracranial pressure going on. So you want to look at the neuro and the vital signs first, and then you notify your provider. So reorienting the patient, I don't think it's going to change anything much. Give PRN lorazepam. Eventually, you probably think about that, but for now, you don't want to jump to that. And then dim the lights. Yes, you'll eventually do that, but first you want to go ahead and assess your pupils and your vital signs and see where you're going. Then let your provider know. All right. Which task is appropriate for your UAP? The UAP is the who is that again? Is that the same thing as the unlicensed assistant UAP? So the unlicensed assistive personnel. Okay. Hard to see that. So what is... Okay, so what task is appropriate for your unlicensed assisted personnel? A, teach a patient about incentives in spirometry. Yes, sachet. B is obtain a sterile urine specimen. C, feed a stable stroke patient after swallow screen. D, assess the pain after analgesic. Which of those would you delegate to your UAP? So is it you're going to teach, have them go ahead and teach, about incentive spirometry? Are they going to be going to obtain a sterile sample, feed a stable stroke client after a swallow screen, or assess the patient's pain after analgesic? Just need one answer. D, assess the pain after analgesic. Do we have another one? I don't know. Yeah, the UAP was a little bit, I've never really seen that one before, but I know what they're talking. But remember, if you're going to be doing any form of delegation, you cannot delegate anything that has to do with assessment or teaching. All right, that is the primary responsibility for the RN. So the one that says teach, or if you're going to educate, teach incentive, that's going to be for the nurse, all right, the RN. Assess the pain after analgesic is going to be for the RN as well, all right. Obtaining a sterile urine specimen, remember they're unlicensed, so you can give them anything like that. Feed a stable stroke patient after a swallow screen, because remember you'd have already assessed and make sure you've done the dysphagia screening to make sure that this patient is able to, swallow, or you do the swallow test already. So you know that this patient is going to be able to swallow and not be choking on anything that you or the unlicensed person is going to be able to give that patient. So definitely, because of the word stable stroke, that makes the entire, answer different, as well as the swallow screen, the fact that they made mention after a swallow screen. If it was a case where they say feed a stroke client, then definitely you wouldn't go ahead and ask an unlicensed person, because you're going to have to be there evaluating to see if this patient is able to swallow. So what you're going to be doing is basically doing a swallow test at that time. All right. But because it says feed a stable stroke client after a swallow screen, then, you can always go ahead and do that. Assess pain after analgesic is for the nurse. Feed the stable stroke is going to be for the UAP. Obtain the urine specimen is going to be for the UAP. And teaching is going to be for the nurse. All right. So UAP can assist with feeding if it is safe. Teaching, sterile task, assessment is equal to, your duty as a RN. All right. All right. One more OB case. Monica, I am doing well. Thank you so much for tuning in. How are you doing? All right. So which finding indicates worsening preeclampsia? All right. Is it A, blood pressure of 138/88? B is going to be +1 proteinuria, which is the urine having protein. C, epigastric or right upper quadrant pain. Or D, mild pedal edema. Which of these answers are saying that this patient is having worsening preeclampsia? Is it the blood pressure of 138/88? Is it the proteinuria? Is it the epigastric or right upper quadrant pain, or the pedal edema, which is a swelling in the lower extremity? Or we know what preeclampsia is, all right? We know what that is. So usually when you have anybody with preeclampsia, you're looking out for protein in the urine, there are changes in their blood pressure, the blood pressure becomes high, and a lot of times they have swelling in the lower extremity. So when you go to the doctors as a pregnant woman, every time they do a a urine test and you say, Lord, what am I doing that urine test here for? Yes, it's to identify from early because you don't want it to, be something that is missed and you move on to like eclampsia phase where it's a little bit more complicated and then causing more problems during your pregnancy. So you're always looking out for your urine with your protein. You're always looking out for, your hands or the legs being swollen, and you also check in the blood pressure as well. So if you see a patient and the patient has the blood pressure of 138, yes, question mark beside that one because it's elevated. All right, so you want to keep it a little bit lower if possible. So you're going to keep an eye on that patient. The proteinuria 1 plus, we can say, that is not really worsening, probably just in the same little preeclampsia phase there, but it's not worsening. The mild pedal edema, it's mild, so it's not worsening. So the answer they have is the epigastric or the right upper quadrant pain, which might indicate hepatic involvement, which is usually severe. That is usually a severe feature. So all the others are more just a preeclampsia mild phase. But because the answer it says worsening, then the answer here is epigastric or right upper quadrant. But I guess, if we're studying a little bit broader, I will read a little bit more about, the different stages, the preeclamptic stage and the eclamptic stage, then we can know that, okay, the liver is involved, so probably would have chosen that answer. All right. So the hepatic involvement usually is a severe feature when you're thinking about a patient who is pregnant and having symptoms of eclampsia. All right. For pediatric patient, which of these is the best indicator of rehydration in a toddler with gastroenteritis? So we're thinking rehydration, not dehydration. All right. So the patient is dehydrated. We have hydrated the patient. Which is the best indicator that, this patient is coming back to, their normal? So is it a patient that is tearful when crying? Is it moist mucous membrane? All right, I think we interpret it wrong. Urine output less than 1 ml per kilogram per hour, or normal cap refill. So dehydration we're talking about here. All right. So best indicator of rehydration in a toddler with GI gastroenteritis, is it someone that is crying? So usually if they're dehydrated, they might not be crying. All right, so they might not be crying. They might not be having any tears. So they might be crying, but there is no tears because their body just dry out. All right, so definitely if they're dehydrated, they're not going to be having any tears. The mucous membrane will look dry. All right, so if you see a child and their eyes are sunken, they're crying and they're not having any tears, mucous membrane is dry, then most of the time they're dehydrated. All right, and if they're not peeing, if the mom comes and says, well, the last time the child, pee was like 6 hours ago and you've been trying to feed them, they're fussy, they're not drinking, or they're vomiting, but they're not putting out any urine, then that is something that you want to be looking at. You also want to check on their skin as well. All right, so the cap refill, if it is normal, then that's a normal sign for the patient. Moist mucous membrane is okay. Tearful crying is okay. But if you have a urine output of less than, 1 ml per kilo per hour, that's like, almost 1 tablespoon. If you're having that output, that's no output at all. So you want to make sure you start force some fluids on that child to get that child, start peeing or start making some tears, something like that. All right. So the mucous membrane, but the mucous membrane is moist. If it was like dry, then definitely that child would be very dehydrated. All right. So look here, help me to, you hear me there? Say all of the other one. But anyways, we get it. So the best indicator for rehydration, I was just thinking that you've hydrated the patient, but it's more dehydration in a toddler with gastroenteritis. Which of them is the best indicator? Is the fact that the urine output is going to be very, very poor. All right. So urine output is the most reliable indicator for hydration in a patient. All right. A client on hemodialysis, has crackles and the blood pressure is 190 over 100 post-treatment. What is priority for this patient? All right, so this patient is on hemodialysis and has crackles and the blood pressure is 190 over 100 post-treatment. So you just, dialyze this patient and the blood pressure is still high. The patient still has crackles. What is it that you're going to be doing next? All right, what is the priority? Is it that you're going to assess the weight, assess the weight of the patient? You're going to administer PRN antihypertensive for this patient. C is that you're going to elevate the head of the bed and give oxygen. Or D, you're going to encourage fluids. Which of these you're going to be doing for this patient? You just dialyze this patient. The blood pressure is elevated at 190 over 100 and the patient still has crackles in the heart, the lungs. What is it that you're going to be doing for this patient? Is it assess the weight? But when we assess the weight, what we're going to do, it's not going to change anything regarding the crackles, all right? You're not going to do anything like that. It's not going to change anything. The patient is still going to have blood pressure being high and the crackles are still going to be there, even though you weigh the patient and you see that the patient is like 200 pounds or whatever it is. Is it that you're going to administer PRN antihypertensive? Yes, the blood pressure is high and you definitely want the blood pressure down a little bit more, but the patient just had dialysis. So we're not likely it's going to drop a little bit. So we're going to kind of hold off on that for a little bit right now. Is it that you're going to elevate the head of the bed and give oxygen to that patient? Or is it that you're going to give the patient more fluids to drink and drown the patient? Well, not necessarily drown, but you don't want to give them too much fluids. So which of them is priority for that patient or at that time? So we would say elevate the patient head of bed, definitely, because then now you're thinking about breathing. So you want to make sure that the head of the bed is good because the crackles are there. Make sure that, the patient is oxygenating properly. So you want to go ahead and elevate the head of the bed, give a little bit of oxygen, and then from there, you give them a Snickers bar. Yeah, man, you can put it at the side of the bed, but tell them not to eat it yet. Welcome, Island Breezy. All right, thank you so much for tuning in. All right, so signs of fluid overload with respiratory compromise is what is going on here because the patient has crackles on the lungs. Blood pressure is elevated there. The patient just had, treatment for dialysis. So you'd be thinking that, that would have improved, but it didn't. The patient has a crackle, so you definitely want to make sure you're protecting or you're assessing the airway, breathing, make sure that it's fine, patient is ventilating well, and then you can address anything else that is going on. Which statement shows understanding of naloxone? All right, and we know what naloxone is or Narcan. That's the same thing. All right, so if you understand what naloxone is, that's the medication that we give to reverse, any form of narcotic overdose. All right, so it's the same thing as Narcan. And which statement shows understanding of it? All right, it may wear off before opioid does. It prevents withdrawal. I only need one dose, or it treats patients too. So these are what the patient is saying to you. So you're going to explain to the patient, you say, okay, then we're prescribing the Narcan because you are on oxycodone, and this is when you're going to be using it. But the patient come back and tell you that this is what they understand. They're going to come and say, it may wear off before the opioid does. Is that something that is correct about what Narcan does? So if you understand the mechanism of action for Narcan, then you're able to answer the question. It prevents withdrawal. Does Narcan does that? Because a lot of patients, they walk around with their Narcan and, they take their medication, overdose, somebody go there and give them, but they wake up 2 hours later and them still want more. You understand? So it doesn't prevent withdrawal any at all. The patients are still hooked onto this thing. All right. I need only one dose. They take so much. They need 10. Yeah, a ton of it. All right. And it treats pain too. Well, but the answer, if somebody comes to you and say that, it may wear off before the opioid does, then definitely it is, because it is short in terms of the half-life. All right, so a lot of times when we see them in the emergency room, we give them the Narcan and it might not work that well. So we have to observe them, and just in case we might have to give them more. All right, because it's short acting, yes. All right, so shorter half-life than many opioids, monitor for resedation and repeat dosing. So as I say, you might give one dose and it doesn't, reverse. Then you have to go ahead and give another one, another one, another one until the patient is, awake and alert, and then you monitor them. Yeah, short acting. All right. Best response to a grieving spouse who says, I can't go without them. If somebody comes to you and say they're grieving, I can't go without them, that is what they're saying. So they've lost, a husband, a wife, and they say that to you. What is it that your response is gonna be? You have to stay strong. Or B, tell me more about what can't go on means for you. Time heals all wounds, and you should join a support group. What is your best response to that patient? So somebody comes up and they're, you know that they just lose their husband, their wife, and they say, I can't live without that person. The next thing you're going to say, so what are you going to do? What are you going to do? Like, things like that. You're going to try to find out a little bit more about what this person is going to be doing. Because during that time, you want to make sure that that patient is not suicidal. Because a lot of times, we kind of think differently. So we decide that we're going to join them as well because we can't live without them. So you want to find out from that person what is happening. All right. Probe into the situation. So you're going to say, tell me more about what can't go on means for you. All right. So you just try to get a little bit more information from them. You have to stay strong. A lot of times, we tend to say that, but we have to try to find out, because when you tell somebody to say, you have to stay strong. Like, okay, then the people them can't live without the people. You understand? They can't live without the husband, can't live without the wife. So how are they gonna stay strong during that time? It's gonna be difficult. Or when we go ahead and say time heals all wounds, because yes, we always say that, and you should join a support group. Yes, definitely these are things that you can say, but that is not gonna be the appropriate thing. You want to find out if this person is suicidal. All right, so definitely do that, and then from there. So open-ended exploration questions always are important, because you're trying to find out how this patient is feeling. You're trying to identify, if this patient is at risk for suicide. All right. Which client with ulcerative colitis needs immediate attention? A patient who is having 6 stools today, abdominal cramping revealed by bowel movement. Not a problem, Bliss. Thank you so much for tuning in. Temperature of 102.2 and a tachycardia or urgency and tenesmus. Which client with ulcerative colitis needs immediate attention? Is it somebody that is passing a lot of stools per day? So 6 stools today. So person have diarrhea, which is pretty, common in ulcerative colitis. Abdominal cramping relieved by bowel movement, which is, the abdominal cramping is also something that is very common. Temperature of 102, so that patient is frying, all right? And the patient is tachycardic. Urgency and tenesmus. So even though, you definitely want to address all of those, you want to go ahead with the tachycardia and the 102.2 temperature, all right? This patient is frying, so you definitely want to go ahead and make sure that there is no systemic involvement. Well, it's already involved because the patient is having fever. So you want to go ahead and make sure you're checking all of that for the patient, and then from there, you can address everything else. So fever and tachycardia may signal toxic megacolon or systemic infection. All right. So you want to make sure, probably going to have to take this patient to the operating room. I don't know what it is, but something is going to need to be done for this patient to prevent this patient from going into shock. Definitely, blessed soul. All right, so you want to get that temperature down, get the heart rate down and all. All right, and see whatever part of the colon you can before, things get worse. All right. A client on 2 liters of oxygen via nasal cannula has frequent mouth breathing and the dryness. What is the best intervention here for that patient? So the patient is on 2 liters of oxygen via the nasal cannula, but the patient is doing a lot of mouth breathing and dryness. What is the best intervention? Switch to a non-rebreather, Add humidification, increase it to 6 liters, or switch to room air between naps. What would you do for that patient? So if the patient is under 2 liters via nasal cannula and, the patient is breathing via the mouth and they have a lot of dryness in the nasal passage, what is it that you're going to be doing? Sachet says B, which is add humidification. Yes. All right. So definitely that's what you'd want to do. Switch to a non-rebreather. Why would you give them a non-rebreather? Increase oxygen. But why? What if this patient is a COPD? You increase the oxygen and then what happens for that COPD patient? All right. So you can't switch to the non-rebreather because you definitely want the patient to be on 2 liters. The non-rebreather is going to give you a higher concentration of the oxygen, so you don't want that to be happening. Increase into 6 liters. Unless the saturation is low, then definitely. But the doctor says this is what we want because we just want a little, extra room air, kind of. Let's just say. You don't want the patient to be on too much. But remember, the patient is having frequent breathing and there's dryness. So more than likely, the dry oxygen is just drying out the nasal passage. So the only thing you need to do is get the patient connected to a humidifier to get that oxygen a little bit more humidified and moisten the passage for that patient. And then it says switch to room air between naps. Well, if they can switch to room air, then I don't need to keep them on the nasal, the nasal cannula as far as I'm concerned. But I would say stick with the humidification because that is going to reduce the drying with the low oxygen flow. All right, because I say the question made mention of the mouth breathing and the dryness. So they're telling you that it's not necessarily the concentration of the oxygen that is the problem. It's the fact that the patient is getting it and it's drying out their nasal passage. Increase oxygen and it's still not humidified. Yes, more dryness. Exactly. All right, definitely. Which statement requires follow-up for a client on lithium? All right. So I don't really know much about psych like that. But anyways, let's get on to lithium. I'll keep my salt intake consistent. B, I'll drink plenty of water. C, I can take ibuprofen daily for headaches. And I'll get my blood levels checked. All right. So which statement requires follow-up for a client on lithium? I'll keep my salt intake consistent. I'll drink plenty of water. I can take ibuprofen daily for headaches. And I'll get my blood levels checked. The answer is going to be C. All right, it says, so if a patient comes to you and say, I can take ibuprofen daily for headaches, and the patient is on lithium, because they're saying that NSAIDs can cause increase in lithium levels. So definitely if somebody comes and say, oh, I can take the ibuprofen, Aleve, and they're taking lithium, then they're not aware of, what is happening with the medication. All right, so you want to make sure that you don't encourage them to take any form of ibuprofen, Aleve, NSAIDs, because that's contraindicated for a patient on lithium. Omit NSAIDs. Yes. All right. They definitely need to get their blood levels checked. You need to get that checked. Drink plenty of fluids. I'll keep my salt intake consistent. All right, so definitely do that. All right, let's get to this med search question. Are we still awake or are we sleeping? Can we just double tap up the live a little bit for me, please? Let's go to, I'm not that greedy. Just need to go to 6.5. So just 500 more taps on the live. Hello, hello, hello. You're getting sleepy. I know. Thank you so much though for tuning in. All right. So we're gonna go to somebody sending me something. Oh, Blessed Soul, you're sending me a request. Let's see if that is correct. Okay. Hola. All right. So until she gets connected or he gets connected, let's go. All right. So a client with chest tube has continuous bubbling in the water seal drainage. What should the nurse do? All right. So you notice that you have a patient with chest tube and they have the water seal drain chamber there. What is it that you're going to do for that patient? Document as normal. notify the provider immediately, clamp the chest tube, or check for an air leak. What is it that you're going to be doing for this patient? All right, and remember, it's happening now, so you want to go ahead and deal with the situation. So is it a case you're going to document as normal? Is that normal for you to have that continuous bubbling in the water seal drainage? No, so it's not normal, all right? Notify the provider immediately, but when you're going to notify the doc, you're going to call and say, hey, doc, there's bubbling in the water, you know, in the water seal drainage for the chest tube, but it's still happening. You're not addressing that problem. You understand? So what are you going to be doing? Are you going to clamp the chest tube, or are you going to check for air leak? You're going to check for air leak, definitely, all right? You're expecting, you know, intermittent bubbling. So you can have, every time the patient breathe in, breathe out, you're going to have a little bit of a bubble there. But if you realize that there is constant bubbling there, then definitely there is an air leak. So you want to go ahead and address that, all right? So sometimes you can go ahead and just check the site there. You're not going to occlude it, all right? You're not going to occlude it completely. You want to make sure that there's a little area, but you want to not clamp the tubing as well, all right? You don't want to clamp the tubing as well. So continuous bubbling is equivalent to air leak. Intermittent bubbling is expected. Never clamp without an order, all right? Then now you want to go on to, do not do that one. All right, let's go on to this one. Any question on that one? All right, so let's go on to this one. Which client do you assess first? A post-op client with a temperature of 100.2, a client with asthma and audible wheezing, a client who is 2 days post-op hip surgery requesting for pain meds, or a client scheduled for discharge needing education. So you have those 4 patients. Who is it that you're going to run to first? Is it the post-op client with a temperature of 102? 100.2, 100.2. A client who is asthmatic and is having audible wheezing. Is the client who is 2 days post-op surgery requesting for pain medication, or a client who's scheduled for discharge needing education. Who is it that you're going to go to first out of your 4 patients you're assigned to? You just walk into the shift and you see those 4 patients. Who are you going to, or who is it you're going to see first, or are you going to see now?
Would it be the patient with the high temperature of 102?
No. Do we have another? The post-op? No. Remember, always, everything that you're doing, ABC, neuro, all right? ABC, Tash says the asthmatic, definitely, all right? You always want to address the airway first. Post-op client, yes, you want to address, but not priority out of these 4 patients, not the first person you're going to run to. So patient who is asthmatic and having wheezing, meaning that, you know, the little straw, yes, it's like this now, because they're so constricted. You want to address that patient first, get their airway sorted out so, you know, they don't crash on you. And then from there, you can always go to your patient with the temperature, or you can go to the post-op pain patient, depending on, you know, how things are going. And then the last patient out of this list is going to be the discharge patient. All right, so always use your airway, breathing, circulation, neuro as your guide in terms of who you'll run to first. All right, so wheezing equals the airway compromise, always the highest priority. All right, then we have a client with heart failure on furosemide develops muscle cramps and weakness. Which lab do you check? So you have a client who's on heart failure and on furosemide or Lasix. Which of the labs are you more concerned about if the patient is complaining of muscle cramps and weakness? So is it sodium, potassium, hemoglobin, or calcium?
Would it be the potassium?
Because we know that with potassium, we pee out, you know, they lose a lot of potassium. They lose, with furosemide, we lose a lot of potassium, sodium, chloride, all right? So you'll have a lot of, yes, you excrete a lot of your potassium. So definitely you want to make sure you're checking for your potassium as well. And with hypokalemia, you tend to have muscle cramps, weakness and all. All right. Sodium, definitely you'll check that as well. Hemoglobin, nah. Calcium, nah. So definitely furosemide, all right, because you lose a lot of sodium. You lose a lot of sodium and potassium, but mostly if you're thinking about the muscle cramps, it's going to be the potassium. So hypokalemia is common with loop diuretics, muscle weakness, arrhythmias is what you're concerned about. All right. Which patient should be assigned to a private room? The MRSA patient who has a wound infection, varicella, influenza, or the C. diff?
Repeat it. Influenza?
So you have the C. diff, influenza, varicella, or the MRSA patient. Who will you put in the private room? You have one, all of these 4 patients present, and you have one room. Who would you put in that room? Is it the patient that is pooping a lot? Is it the patient who has the flu? Is it the patient that has varicella or the chicken pox? Or is it the MRSA patient with a wound infection? So if we know which patient, so with the C. diff, that is what precaution. C. diff is going to be the contact precaution. Influenza is going to be like droplet precaution as well, contact. Varicella is going to be the airborne precaution, and the MRSA is going to be a contact precaution. So you want to definitely put your airborne precaution away because you don't want everybody else to have, varicella, especially when you think about those, the pustules there being open. All right. You don't want it to be a case where everybody is inhaling and then getting varicella there. So definitely you want to put away your airborne precaution patients. So varicella equal to airborne isolation plus negative pressure, private room required. The others can cohort with the same organism. All right. Which client should not receive morphine IV? Is the client with MI pain, myocardial infarction pain? Is the client with severe burn pain? A client with respiratory rate of 8? Or is the client with fractured femur pain? Which patient you wouldn't give morphine to? Is the patient who is having a heart attack and is complaining of pain? Is the patient who has severe burns pain, respiratory rate of 8? Breaths per minute, or is the client who has a fracture in the femur and is having pain? Respiratory rate of 8, Tash is saying. Okay. Do we have anybody else?
One with a heart attack.
Heart attack. Okay. Do we have anybody else? Just one more. A, B, C, D. C, and Sashay says C. So the answer is gonna be the one with the respiratory rate of 8. All right. So remember, whichever client should not receive morphine. Morphine is a narcotic, and when a lot of persons tend to get narcotic, their respiratory, they tend to have respiratory depression. All right. So you want to make sure that if they're already depressed in terms of the heart rate, not the heart rate, but the respiratory rate is 8. They're not breathing properly. They're bradycnic. All right, so they have slow respiratory rate. So if they're already low on their respiratory rate, you don't want to give them any form of narcotic that is going to cause any further suppression of their respiratory rate. So definitely you're going to hold it for any respiratory rate under 12, all right, because of the risk for respiratory depression. All right, the myocardial infarction, always remember, Mona, you can give you morphine, oxygen, nitroglycerin, aspirin. So for the client with MI, it's okay to go ahead and give the morphine. Severe burn, it's good. You can give them, especially if they're, hyperventilating. That will also help with their respiratory rate as well. All right, so it will kind of tackle 2 things. And then the patient with a fractured femur, definitely they're having pain. Nothing is wrong with giving them the morphine. But if you notice that their respiratory rate is already low, you want to hold it and then, address their respiratory rate, and then you can always address pain later on. All right. All right. This is who now. Which finding is abnormal in a postpartum client? So this patient has had baby. Which one is abnormal? Lochia rubra, which is day 3. Fundus midline and firm. Passing clots the size of a golf ball. Mild cramping with breastfeeding. Which one is abnormal for a patient who has just delivered? They're 3 days out of the hospital, or they're in the hospital, and they have the lochia, which is the blood, when they have the blood after birth. Usually they'll have the bleeding. It can go up to a couple of weeks. Well, all right, they'll have it a couple of weeks, after delivery. But as the days goes by, the bleeding, the color, it changes. All right, so it will be like bright red, and then it probably turn brown, and then it might, some spotting. So over time, it's gonna decrease. So that lochia. So which of this is abnormal? Is it the lochia rubra on day 3? Is it the fundus midline and firm? Is it passing clots the size of the golf ball and mild cramping and with breastfeeding? Definitely it's gonna be, yes, sachet the C. Passing the clots the size of a golf ball. You don't want to be passing clots the size of a golf ball at that time. All right, that's too big. The fundus midline and firm means that, yes, there is low risk for any form of hemorrhage. So definitely they did a good job with the massage after delivery. So there shouldn't be that much of a heavy bleeding. The mild cramping with breastfeeding is good because you have like the contraction going on. So when the child is sucking, you're having that contraction, so it's going to decrease any form of bleeding. But if you're passing those large clots the size of the golf ball, 3 days later, it means that they never did a good massage, or you're still at risk for hemorrhage, postpartum hemorrhage. So you want to make sure that you address that. All right, so large clots equal to abnormal bleeding. Normal small clots is okay, and mild cramping is okay. All right. Which nursing intervention is the most appropriate during an acute psychotic episode? Is it you confront the delusional patient directly? Or B, you provide reality-based brief interactions with those patients? C, encourage detailed discussions about hallucinations? Or do you leave the client alone until calm? So you have this psych patient who is having an episode. Is it that you're going to go to the patient and try to confront them while they're in their delusional state? All right.
Leave them.
Huh?
Leave them alone.
You're going to leave them alone? No, man, and then they mash up the entire place?
Sometimes you have to, though. Sometimes you have to leave them alone.
Yes, you can. All right, but out of the 4, the 4 interventions you have here, what can you do? There's always something that you can do for the patient outside of, leaving them alone. What can you do for this patient here? Confront the delusional patient directly. No.
Try to de-escalate it and talk to them.
Yes, exactly. So provide reality-based brief interactions with the patient. So you want to try to talk with the patient. You understand? Let them know that this is what is real, in a sense. You understand? So even though they might say that, they see Jesus coming down from, the sky, get them back to reality. Let them know what is happening. So you take a little time and just kind of, bring them back to reality with whatever is happening there. And then from there, but leaving them alone until they're calm. What if them probably not get calm? You understand? What if it take you it takes them like 2 hours, 3 hours? They're going to be in that same state. So always try something first, and then from there, encourage detailed discussions about hallucinations. You don't really want to talk about it like that. You understand? Because the conversation is still going to be about Jesus coming down from the sky, because that is what, their reality is at that time. That is what they're experiencing. So that is what they're going to discuss with you. So definitely you want to go ahead with the short reality-based contact, which reduces anxiety. You don't want to confront them, and you don't want to reinforce their delusions. All right? So when they're having that little episode, make sure you're not encouraging, you're not trying to have them talk about their hallucinations or anything like that. Try to get them back to reality. All right? The diabetic patient. Which finding in a diabetic client is most concerning? So which of the finding is most concerning for a diabetic client? Numbness in the feet, blood sugar of 210, sweating, tremors, and confusion, or poor skin turgor? So which of them is most concerning? Is it the numbness in the feet, the blood sugar being elevated at 210, sweating, tremors, confusion, or poor skin turgle. Okay, so Tash says C. Do we have anybody else saying anything else? My YT folks? Yes. You can answer as well. I just need one more answer. A, B, C, D. So numbness in the feet, blood sugar of 210, sweating, tremors, confusion, or poor skin turgle. Which one do we say? Sasha, you just joined again. Which one do you say? Just give a number, a letter. A, B, C, or D? All right. So Tash says C, and the answer is C. So if you have a diabetic client and they're complaining of sweating, or you notice that they're sweaty, they're having tremors, they're confused, you're thinking about, you know, the glucose being low. All right. So definitely you want to be concerned about hypoglycemia. So of the 4 patients that you have, and you go in, and this one says, my legs are feeling numb. Yeah, you can, you know, put a question mark beside that one and come back to that patient. Blood sugar glucose of 210, elevated, is a diabetic patient. We can always address that one later. But the patient that is sweaty, having tremors and confused, definitely you want to address that patient. Find out what is happening. Go and get the glucose, check on that patient. More than likely it's low. Give them something to eat, or, you know, give them some glucose, and that usually bring it up and try to correct those tremors, the, you know, the confusion and the sweating. The poor skin turgle is something as well that you can address, but it's not a dire emergency, probably because the patient is dehydrated. The numbness in the feet, as I say, why you'd put a question mark beside that one, you just want to probably get a little bit more information and to see if there's any other symptoms apart from the numbness. If it is in both legs and not really thinking about a stroke, it could be just like, you know, neuropathy from the diabetes that they're having. So definitely the one that is sweaty is the most concerning. All right. So hypoglycemic symptoms, which we listed, the sweating, tremors, confusion, you want to identify those because that patient is going to be at immediate risk for seizure as well as coma. All right. So you want to address that. Which vital sign requires immediate intervention? Is it the blood pressure of 144/90, heart rate of 58 in an athlete? Is it a respiratory rate of 8 breaths per minute, or is it a temperature of 100.8? Which vital signs is requiring you to drop everything and go to that patient? So everybody is there. You go in and you hear that, oh, this respiratory rate is 8. Which patient is you're going to be seeing? Is it the one that has a temperature of 100.8? Yes, the patient is fine, but can actually hang out a little bit. Is the patient that has a respiratory rate of 8? Is it an athlete that has a respiratory rate of a heart rate of 58? They can also have a heart rate of 40 in an athlete, and you know, huh?
They're usually fine. Athletes with low.
Yes, if they're not symptomatic, they're fine. And then the blood pressure 144/90. Who would you run to first? The respiratory rate? Exactly, exactly. That is just too low. You know, you can give a Tylenol or Motrin to the temperature of 100.8, 30 minutes time, you know, it's reverse. The 58 heart rate in a athlete, that is not bad. That is like probably normal for them. You understand? Sometimes you'll see them there at 40 and it's okay. 144/90, you give them the blood pressure medication, they're okay. All right. But always remember, ABC is what we are using when you're doing any of the answers. All right. So always go back to that. So the respiratory rate is less than 12. Inadequate ventilation, it is life-threatening. So definitely you want to drop everything else and run to that patient. All right. So that is the one that is going to be requiring your immediate intervention. All right. So a patient, this is a pediatric child with RSV. Which action is priority for the child with RSV? Give cough syrup, encourage oral fluids, maintain airway with suctioning, or start antibiotics. What is the first thing you're going to do with a patient with RSV? So a lot of times they tend to find out that these babies tend to have a lot of congestion. They have a lot of secretion. They have the fever, you know. So definitely you want to make sure airway is always clear in these children. Ooh, where is that? Like so far. So you want to make sure airway is good. So which action is priority? So you have, you know, this baby here. What is the most important thing here for this child? Is it giving the cough syrup, encouraging oral fluids, maintaining airway with suctioning, or start antibiotics? Anyone on YT want to answer? All right. So as I said, the priority is going to be, you know, you always want to focus on the airway, breathing, circulation. Always do that. There are three answers here regarding airway, you know, that, well, can affect the airway. So giving the cough syrup, what if the child has too much, you know, secretion there? Giving the cough syrup is just going to cause that child to, you know, choke on that as well. You're going to have them aspirate. Encourage oral fluids is the same thing. If they already have too much secretion, you give them more fluids, they're going to choke on that. They're going to aspirate. So the most important thing is to maintain their airway. Clear the airway, and then you can always go ahead and push your fluids, have them drink the cough syrup, and then from there, you know, they will improve. And then starting antibiotics. Yes, you'll start your antibiotics, but the most important thing is to make sure the airway is clear for you to go ahead and do everything else. They're oxygenating well. When you give them the cough syrup, they're taking it, you know, you're giving them their little fluid, they're taking it in. So you want to make sure that airway is clear of any secretion, and then from there, you do everything else. All right. So RSV equal to airway management first. Antibiotics not helpful. Oh, yeah, it's a virus. All right, so definitely they're not going to do the antibiotics. All right, so magnesium sulfate. Should we do this one? Which finding requires stopping magnesium infusion? Respiratory rate of 10, urine output of 40, blood pressure of 150/92, or DTRs +2. Which of these requires stopping magnesium infusion? Do we have any OB nurse here? Let's see what this is. All right. So DTRs +2 is deep tendon reflex +2. So which of them requires stopping magnesium, stopping the magnesium infusion? DTRs ×2, deep tendon reflex +2, respiratory rate of 10, urine output 40, or the blood pressure 150/92. Okay, the respiratory rate of 10. Okay. Okay. Do we have anybody else with another? DTRs. Deep tendon reflexes. All right. So which of them requires stopping the magnesium? The answer is B, the respiratory rate of 10. So there's a respiratory rate less than 12 equals the magnesium toxicity. So you want to go ahead and stop the infusion and go ahead and give your magnesium, your calcium gluconate. All right. But even if we probably don't know the answer, let's just try and see if we can actually figure it out. You see the respiratory rate of 10. That patient is, the respiratory rate is very low there. Urine output 40 mL/h. Look like something we can work with, right? And then the blood pressure 150/92. Looks like something we can work with. Okay, so we'll probably keep those. So the only two that probably, you know, if you're a new nurse and you're there wondering which of the answer, if you don't know, you know, anything about the magnesium and the effects, then probably you'd be there between the DTRs, because probably you'd be wondering what DTRs, you know, is. And then from there, you probably would say, okay, then the respiratory rate is 10, that's low. Probably we'll go with that. So, try to eliminate as you go along, and then from there, hopefully, you probably just get the answer correct if it is something that you're not familiar with. All right. All right. Which statement shows the need for further teaching? I'll keep oxygen tank away from open flames. Patient saying that to you. I can use petroleum jelly on dry lips. I'll post a no smoking sign, and I'll check tubings for kink. So which statement shows the need for teaching, further teaching? So try to find out what is okay in the question. I'll keep oxygen tank away from open flame. So remember, this is oxygen. So do you want it close to the open flame? No. So definitely you're going to eliminate that one, because that patient would have been, educated well. I can use petroleum jelly on dry lips. We probably don't know much. It sounds simple, but we're going to put a question mark beside it. Why? I'll post a no smoking sign. Definitely, you want to put up that, because you don't want anybody come smoking around you when you're on oxygen. And then the other one is I'll check the tubing for kinks. You'll go ahead and check that one. So all of those 3 patients are saying something correct, all right? So the patient is, I can use petroleum jelly on dry lips. Definitely would want something on the lips. But the petroleum jelly is flammable, all right? So you don't want to mix it with the oxygen there. So if it is water-based jelly, you're going to use on the lips, it's okay. But if it is petroleum, then definitely you want to not use that one. So if you're not so sure the answer, always go with, read the question over and then find out what is correct. And then the one that don't make any sense to you, then you go ahead and eliminate it. All right? So petroleum-based products are flammable with oxygen, so use a water-based product only. All right? Which action is priority during a seizure? Process of elimination. Definitely. Which action is priority during a seizure? Inserting a tongue blade? Is it turning the client on the side? Is it restrain movements? Or apply oxygen via mask? What is priority during a seizure? So this patient is like seizing. What is it that you're going to be doing for that patient at that time? Are you going to try to insert a tongue blade at that time in the patient's mouth? So I'm seizing like this. Are you going to try to put something in my mouth? Turn the client on the side. Okay. Turn this client on the side. Definitely you want to do that. Is it restraining movements? Is it applying oxygen via mask? You can be applying, oxygen via mask, but you don't want to do that at that time. You want to make sure that you turn the patient on the side. So anything that is, the secretion is drooling, it's draining out. It's not going in the back of the patient's, mouth to cause, them to choke or aspirate on that. As well as, slightly hold them under the side, prevent any further, injury or anything to their head, things like that. But definitely put them on the side to prevent aspiration is the most important thing. Never put anything in the patient's mouth. You're probably going to try to put in something and they probably bite off your finger. So try and avoid that, all right? So turn them on the side and that's it. All right? So sideline prevents aspiration. Never insert objects or restrain the patient, all right? Let's go on to one more OB case. Placenta previa. Which nursing intervention is contraindicated in placenta previa? And while you're studying, with placenta previa, you will remember that anytime you say placenta previa is previous, placenta previous. Just that's just something I always remember. Placenta previa, previous. So the placenta come down first. All right. So which nursing intervention is contraindicated for this patient who is in placenta previa? Monitor the fetal heart tones. Place the client on bed rest. Prepare for C-section if needed. Perform vaginal examination. So you have all of these things to do for the patient. But this patient has placenta previa, which means the placenta is coming down. All right? That is the first thing that is coming. What is it that you're going to be not doing for this patient? Is it a case you're not going to monitor the fetal heart tones? So the patient still has a baby. Baby is there, but the mother is going through this little difficulty. Are you going to not, monitor the fetal heart tones? No, you still want to monitor fetal heart tones. Place the client on bed rest, definitely, because if the patient stand up, it's going to further cause the placenta to come down. You understand? Because it's literally like tearing away from the, the uterus. Is it prepare the patient for C-section if needed? Definitely you're going to be doing that because, you don't want this patient to bleed out and then you lose the baby and everything that is going on. Is it perform vaginal exam at that time? You definitely don't want to do that. You don't want to be doing any vaginal examination on any patient that has their placenta ripping apart from their uterus. So you're going to hold off on that because of the risk for, hemorrhage. So avoid any form of vaginal examination during that time. All right. Any question? Thank you so much for following Dark Honey Cooks. And thank you guys for tuning in on YT as well. And if you're new here, follow me on YT at ThinkNursing. I share the long form of my live or everything that I post on TikTok over by YT. And YT folks, go ahead and subscribe on my TikTok at ThinkNursing1. All right, I share short form content and a ton of things. All right, so join me over there, please. All right, so can we get some likes on the live, please? Just a little bit of live. Let me drink some water. Just a little bit of a live. Yeah, just tap up the live. All right. All right, let's go on to burns. A burns patient. So it's a med-surg question. A burn client with partial thickness burns is restless. All right, you have a heart rate of 130. You have a blood pressure of 88/60. What is the priority action? So this patient is a burn victim. The heart rate is 130. So I don't know what's going on, but something is going on. All right. And the blood pressure is 88/60. Something is going on. What is it that you're going to do for this patient? Are you going to go over to the patient and say, how is your pain right now? So you're going to reassess the pain at that time. Remember the vital signs, and the patient is restless. Are you going to go and address the patient's pain? Or are you going to be starting IV fluids because you're thinking something is going on with this patient? Are you going to place the patient on oxygen, or are you going to elevate the legs of the patient? What is it that you're going to do for this patient that has partial thickness burns, is very restless, heart rate is 130, and 88/60 is the blood pressure? What is it that you're going to do for this patient? A, B, C, D. So the patient has partial thickness. So you know that the patient losing a lot of fluids. All right. So the patient is at risk for dehydration, hypovolemic shock, that kind of thing. All right. Is hypovolemic shock? Is which one of the shock the patient at risk for? Let's pull that up. Make sure I say it correctly. So shock in burns patient. But the patient is losing a lot of fluids there. Okay, so the patient is going to be at risk for hypovolemic shock, definitely. All right, so you have the patient there at risk for hypovolemic shock because the patient has partial thickness burn. You realize that the heart rate is elevated. It can be because the patient is just in a lot of pain, or the patient is actually in shock as well. You understand why the heart rate is 130. But then you notice the blood pressure is also low. It's 88/60, which is saying that the patient is heading into shock. So what you want to do for this patient is go ahead and start IV fluids. So this patient, you want to get the largest IV on because you want to be pushing fluids. You want to be giving the patient a lot of fluids during this time to make sure that the heart rate goes down, the blood pressure goes up, all right? So the patient doesn't go in the opposite direction of where we want the patient. Because as I say, the patient is losing a lot of fluids. So even though probably, it's the skin, just remember that the patient is losing a lot of fluids there. You might not be able to see it, but the patient is losing a lot. So definitely you want to start your IV fluids. Get your 2 large bore IVs. We're not talking about the ones down here. We're talking about the ones up here. Now the big AC, them closer to the heart. Yes, those are where you want to go ahead and get it. And you're going to put on those, put the fluids on some pressure bags and get those fluids in. Reassessing pain, definitely we will do that. But if you're, based on the priority here, you examine your patient and you see what is happening, you're not going to address pain at that time. You understand? You can only do one thing at a time. So the most important thing is going to be the IV fluids. Then you can go ahead now and get some pain medication. You can probably get your morphine, try to help with relaxing the patient and addressing the pain at the same time. Then you can go ahead and put on some oxygen, elevating the leg of the patient. All of those you can do to help with making sure blood pressure goes up, heart rate goes down. And as I said, the patient is restless, so you want to probably just give the patient something to relax, him or her during that time. All right, so the hypovolemic shock from the fluid loss is priority, and so you definitely want to start your IV fluids. All right. All right, so this one is regarding the thyroid. So you have a patient who is post-thyroidectomy who develops hoarseness and difficulty breathing. What is the first action for you as the nurse? Okay, so C is saying, good evening. What if the patient is in heart failure or renal failure? Okay, so if the patient is in heart failure or renal failure, remember it's always good to, you can always resuscitate the patient and then you can take back the fluid. You understand? So if you're going to try to save the patient, go ahead, bolus the fluid, get the blood pressure up, and then you can always diurese the patient. All right, so they can take the patient back and put the patient on and get like a emergency dialysis. If the patient is a renal patient, you can always go ahead and do your Lasix, your furosemide, your torsemide, and get back that fluid off the patient. All right, so just think about you're trying to save the patient's life. All right, you're thinking about saving the patient's life. So we have medications that can always go ahead and pull back the fluid, but you don't want it to be a case where blood pressure is going down, the patient is tanking, and you're not doing anything to try and help the patient. Give the patient the fluids. Once the blood pressure goes up, heart rate is coming down, then you can always go back now and give the fluid and catheterize the patient, get back the fluid out, and just continue monitoring the patient. All right. So the post-thyroidectomy patient develops hoarseness and difficulty breathing. What is the first action? Check for stridor, reassess the client, place in the high Fowler's position, or you're going to prepare the patient for emergency tracheostomy. All right, so this patient just came out of a thyroid procedure, and now they're having hoarseness and they're having difficulty breathing. What are we thinking that we're going to be doing for this patient? So we're back to the same thing we've been preaching all evening, ABCs, right? So airway, breathing, circulation, you want to assess the airway first, all right? So why is this patient hoarse? Why is this patient having difficulty breathing? So you're going to evaluate a patient. Are you going to check for stridor? Usually when you have a stridor, there is some form of obstruction going on. So you want to make sure that there is no obstruction there. So go ahead and check the patient. And if that is clear, then you can always move on to other things. All right, but you always want to assess your patient first. Reassuring the patient. Yes, you can reassure the patient, but remember the patient's still hoarse and the patient is still short of breath. It's not going to clear up that. It's not going to change that. It's not going to fix it. All right. So you can talk all you want and say, yes, take some deep breath. Yeah, the patient is, dying. The patient is short of breath. So definitely address that. Place the patient in high Fowler's position. Yes, it will help with expanding. But if there is some form of obstruction going on, you can put the patient up in a position like this all you want. It's not going to fix the problem. Thank you so much, T. Foxworth. All right. And then prepare the patient for emergency tracheostomy. But what if the patient, the operating room is busy? The doctor is taking 20 minutes to put on him clothes. Whatever, something is going on. It's okay. Prepare the patient. But at the end of the day, what is it that you're going to be doing now while you're standing there, with the patient? All right. Not a problem. You definitely want to do something. So go ahead, assess your patient, and then from there, you can do everything else. All right. So assess your ABCs. Stridor is equivalent to obstruction. Prepare the patient for emergency airway. All right. So definitely want to do that. Which task can be assigned to your LPN? Yes, blessed soul. Definitely. Which task can be assigned to your LPN? I remember these are your licensed practical nurse, all right? So who can you delegate these duties to? So you have initial teaching about insulin injection. B is gonna be the IV push morphine for post-op pain. C is gonna be administer oral antibiotics to a stable patient. Or D is gonna be admission assessment. So which of these tasks would you say, mademoiselle or sir, I'm gonna have you go ahead and do it. All right, so remember, C, teaching about insulin injection. B is IV push morphine for post-op pain. Administer oral antibiotics to your clients that are stable. And admission assessment. Remember, this is the LPN we're talking about. All right. Tash says C. Okay, do we have anybody else who wants to try for an answer? And once you know your role, the scope or the responsibility or the duties of your, your support staff, your LPN, CNAs, then you will be able to delegate appropriately. But if you're not familiar with the responsibilities or the roles of each of your support staff, then that is going to be a challenge for you to assess, to delegate your duties. So when it comes on to the RN, always remember that whenever you hear about initial, education, because remember, there are certain duties that, the licensed practical nurse can do. But if you're going to be talking about assessment, the initial assessment has to be done by the nurse, the RN, all right? So the initial teaching about the insulin injection is going to be a responsibility for the RN, not for the LPN. Definitely, blessed soul, RN can delegate to LPN just as long as LPN is competent. Okay. And whatever you're delegating is in their scope. All right. So the initial teaching about the insulin is gonna be for the RN, the registered nurse. All right. The IV push medication is also gonna be for the RN. All right. Administer oral antibiotics to stable client. That one is gonna, you can delegate to your LPN. And the admission assessment, the initial assessment is gonna be for your RN. Also depends on where you are. Definitely. All right, so the LPN can give routine medications to stable patient. And remember that the RNs handles teaching, IV push, and assessment. All right. So just remember what your scope entails. How are we doing? How many of us are sleeping? Yes. So let's pull up this a little. Let's try pull up this here. So let's see the roles and responsibilities of LPNs. All right, so the roles and responsibilities of LPNs. So remember, the LPNs provide direct patient care under the supervision of doctors and registered nurses. Their responsibilities include taking vital signs, administering medications, assisting with daily activities of living, and monitoring patient health. They also play a role in communication, reporting patient concerns, and ensuring patients' comfort. All right. When it comes down to patient care, LPNs provide hands-on care, including bathing, dressing, feeding. They also assist with wound care, catheter care, and basic nursing tasks. Monitoring and reporting, they observe patients for changes in condition, take vital signs, and report any conditions or concerns to the supervising RN. Medication, they administer medications as prescribed following established protocols and under supervision of a registered nurse. Documentation, they maintain accurate patient records, documenting vitals, medications administered, and any observation or interventions. And the list goes on and on. All right. Specific examples administering injections and vaccines, taking and recording vital signs, performing wound care and dressing changes, assist with urinary catheters. But as I say, the initial is what changes everything. All right. So the initial assessment is what changes everything, because remember, they're still taking patients. So a part of their thing is that they're still going to be assessing. They're going to go over there and medicate the patient. They're still going to be assessing the patient. But the initial assessment has to be done by the nurse. All right. Thank you so much for joining, Tim the nurse. Welcome, welcome, welcome. All right, so just bear that in mind. They can do the assessment, they can do the teaching, but the initial is always going to be based on, the nurse. The nurse is going to be the one that does the first assessment, and then everybody else after can do their own assessment and teaching. All right, let's move on to another question. I think I mixed this up. Okay. Let's move on to another question here. We did that one already. We did the burns. Okay. Some jobs that RPN or LPN had to do the initial. Okay. Okay. But as it say, it depends on the protocol, I guess, the facility. But it's changing now. Okay. Well, as long as we know what we're doing at the time, so that way everybody can be practicing safe. That's the most important thing. So just know when you get to your facility, what is the role and the responsibility of each person, so we can delegate appropriately. All right. Which newborn depends on the state board of nursing? And Tim is saying it depends on the state board of nursing. Okay, nice. Okay. All right. So for gestational diabetes, which newborn finding is expected in an infant of a diabetic mother? All right. So is it hyperglycemia, hypoglycemia, hypothermia, or hypocalcemia? Which newborn finding is expected in an infant of a diabetic mother? Hyperglycemia, hypoglycemia, which is low glucose, hypothermia, which is, the temperature is low, or hypocalcemia, which is low calcium. Which of them is expected finding in a diabetic mother, a newborn child? Do we have any answer on that one? All right, so the answer is going to be the hypoglycemia. Yes, Roxy. Are you a gynae nurse or another gynae? OB nurse? Roxy? Tash says hypoglycemia. Yes. Okay. Yes, so no, okay. Blessed soul says hypoglycemia. Okay, so hypoglycemia is correct. The fetus is exposed to maternal hyperglycemia, which you'll have increased insulin. So eventually after birth, they tend to have hypoglycemia from there. So it's important to go ahead and try to start the bonding, have them breastfeed to bring that glucose up after birth. All right. All right. Which client statement is priority to follow up? I can't sleep more than 2 hours at night. Sometimes I just wish I wouldn't wake up. I don't feel like eating anymore. I don't want to go to group therapy. Which client statement is priority? Which of these patients, saying that one of these thing to you, one of these sentence to you, and you're like, okay, then what is going on here? Tash says B. Sometimes I wish I wouldn't wake up. Okay. Anybody else says anything else different? All right. So I can't sleep more than 2 hours a night. Is that something that you would follow up? you'll follow up and find out whether or not they're sleeping probably during the daytime or what they're doing at nights, you know. But if somebody says that to you, probably you won't even do anything much about it. I don't feel like eating anymore. You probably could put a question mark beside that one and come back to them. I don't want to go to group therapy. It could be just somebody that is just stubborn or just don't feel as though, you know, group therapy is for them. You know, different reasons. But if somebody says, I just wish I wouldn't wake up, then you'll be wondering, why is this person not want to, you know, wake up? Why does this person seem like they just want to die, you know? And then from there, you'll probe. So anything that has to do with safety, always address that first, all right? Always address it first, because it can be a case where this patient is having suicidal ideation. This person don't want to be here anymore. So definitely go ahead and find out, why do you feel that way? Why you feel as though you just want to go to sleep and just sleep away? You understand? So always check on that patient first. I don't feel like eating anymore. You know, probably the patient is depressed as well, but you can still probe a little bit more with that one. But out of these 4 patients, the one that wouldn't want to wake up is one that is most concerning here. All right. A client with chest pain reports relief sometimes. Okay, so T Fox says, sometimes I wish I wouldn't wake up. Definitely. All right. A client with chest pain reports relief after sublingual nitroglycerin. Which side effect is expected? All right. So remember, the patient is having chest pain and we decide to go ahead and give nitroglycerin. Which side effect is expected? So we know that, you know, if you know what nitroglycerin does, the mechanism of action for nitroglycerin, then you'll be able to answer. Is it the case that the patient is going to be having constipation? Is the patient going to be having headache? Is the patient going to be having bradycardia? Or is the patient going to have tinnitus or ringing in the ear? Which of those, after the patient really reports to you that they're having relief of their chest pain, there's no more chest pain, nurse. I get the 1 nitroglycerin, no chest pain, but I'm having this terrible headache. Yes, a lot of patients will tell you, no, I don't want the nitroglycerin because it gives me a headache. You understand? Definitely, Tash. T, you're correct. So the headache is the one that is, you know, the side effect that we're expecting. A lot of them don't want it because of that. So sometimes what you can do is just offer them some Tylenol with it. You know, just tell them you'll give them some Tylenol to help with the headache. All right, if you definitely have to give the nitroglycerin. So the constipation, you're not gonna happen with one pill just like that. That is gonna take a few days for you to get constipated. So that one is gonna be out. Bradycardia, sometimes, you know, they probably have their heart rate go down, but it's not something that is, you know, you're looking forward to them reporting or you seeing immediately after you give your, you know, your nitroglycerin. Tinnitus, I don't really know about that one, but you know, if we're, you know, as I say, the headache is the one that is most concerning. A lot of times you also see that their blood pressure drops as well because of the vasodilation that is happening. They tend to have dizziness. They might be a little bit flushed, things like that. All right, and all of that is because of the vasodilation. What Tash said. Headache, yes. All right, so definitely chest pain is gone, but they tend to have a lingering headache. All right. A nurse overhears another nurse discussing a patient in the cafeteria. This is a violation of what? Autonomy, fidelity, HIPAA, beneficence. All right, so you hear somebody talking about another patient in the cafeteria or in the elevator. This is a violation of what for the patient? Okay, T says HIPAA. All right. And if you don't know HIPAA, let's go and read on that. All right. And familiarize yourself with that. All right. You can't be discussing anything about a patient publicly because that violates the patient HIPAA laws. All right. So if there is anything that is going to identify the patient, then definitely, you know, that's a big violation there. All right. Which teaching is correct for a client on ACE inhibitors? All right. And when you talk about the ACE inhibitors, you're talking about your prils, your captopril, lisinopril, all of those medication. All right. So which teaching is correct for a client on ACE inhibitors? I should avoid foods high in potassium. I will stop the medication if I get a cough. I'll take it take it with meals only. This medication causes constipation. So which teaching is correct for a patient on ACE inhibitors? I should avoid foods high in potassium. I will stop the medication if I get a cough. I will take the medication with meals only. And this medication causes constipation. So which of the teaching is correct for a client? So the patient comes to you and they're on, lisinopril, and they're having a lot of coughing, but they say they're going to stop the medication. Is that something that you would be like, okay, then, yeah, it's okay to go ahead and stop it? Or is it something like, they come in and say, oh, I'm having constipation because of this? Is that something related to ACE inhibitors that you'll be concerned about? Or you think it's okay for them to have that? The cough, okay. So T is saying cough. Anybody else saying anything else? Which teaching is correct for a client on ACE inhibitors? All right. So ACE inhibitors can cause your potassium to go up. So you want to avoid any food that is high in potassium. All right. So A is going to be the answer. So if the patient says, I should avoid foods high in potassium, then good. All right. That is something correct about ACE inhibitors. I will stop the medication if I have a cough. A lot of persons will tell you that when they're taking anything with pril, captopril, lisinopril, they tend to have this lingering cough. You don't want to stop them like that. You don't want them to abruptly stop the medication. Try to taper them off it and transition to something else. All right. So the cough is something that is a side effect, but you don't want to stop it immediately. All right. Some persons are still taking the medication and they're coughing for years and they're still alive and well. So don't stop it immediately. You can always switch the medication from there. I'll take the medication with meals only. Well, when they come to the hospital and sometimes, their blood pressure is high, they miss their medication. We don't feed them. We just give them their medication. So they don't have to take it with their meals only. They can take it with, an empty stomach and then they can eat after. This medication causes constipation. That one I'm not so sure, but, definitely they should avoid foods that are high in potassium. All right. So ACE inhibitors can cause hyperkalemia, report cough, but don't stop the medication abruptly. All right. So Lila Boss, welcome. 015. Roxy, thank you for liking up the live. All right. Which finding is most concerning in suspected ectopic pregnancy? All right. If you have a patient who is having you're suspecting ectopic pregnancy which finding is most concerning? All right. Is it unilateral lower abdominal pain, vaginal spotting, shoulder pain and dizziness, or nausea and vomiting? All right. So which finding is most concerning in suspected ectopic pregnancy? And what we know about ectopic pregnancy? It's an emergency. All right. So if you have a patient that comes in and they're having unilateral lower abdominal pain, they're pregnant, you'll be like concerned about it, but you'll be there. And if you have another patient or they have another symptom or sign, they're having vaginal spotting, you'll be like, okay, those are normal in ectopic pregnancy. The nausea and the vomiting, normal in pregnancy as well for some persons, you understand? But then the shoulder pain and the dizziness. Exactly, Tash, correct. The shoulder pain and the dizziness, especially the dizziness. If you don't really know about the shoulder pain, but the dizziness, you're probably thinking about their bleeding, and the bleeding is so heavy, they're losing a lot of blood. So they're becoming symptomatic. They're having that dizziness because of it. So that is showing that it is ruptured. So you definitely want to go ahead and get that patient to the operating room. All right. So the nausea, vomiting, pretty much okay or normal during pregnancy. Not anything that we need to, deal with apart from give you some medication and try to control that. Vaginal spotting, yes, in ectopic pregnancy, you might have it there. Unilateral abdominal pain, you will have that as well. But when it comes on to the shoulder pain and the dizziness is showing that the rupture is so bad where you're now having the dizziness, the blood pressure is probably very low. So you want to address that. All right. Norman Funeral Services, thank you for the follow. How are you guys doing? Hope you guys are still awake. All right. So a client with stroke has slurred speech and facial droop on the right side, what is the priority action? All right, so all of these are going to be important. All right, these are things you're going to definitely be doing. But what is priority for that patient? You walk into the room and you see this patient. What is the first thing you're going to be doing for this patient? Assess the gag reflex, ask the client to smile, obtain the glucose level, or keep the client NPO. What's the first thing you're going to be doing, or what's the priority for this patient? All right, so the patient has a stroke and has a slurred speech. The patient also has a right facial droop. What is it that you're going to be doing? What's the priority? Okay, so assess gag reflex. Dejamins is saying, hi, welcome, welcome, welcome. Do we have anybody else saying anything else apart from the gag reflex? So assess gag reflex, ask the client to smile, obtain the glucose, and keep the client NPO. All right, so no. So the answer is going to be keeping the client NPO because of the risk for aspiration. So you keep the client NPO until you do a swallow evaluation. Definitely, Tash. All right, so you're going to say, you know, the gag reflex. I don't know if I would read, like, you know, we will do that, but not right now. Not right now. We'll eventually do a swallow test on the patient, but not right now. And then the gag reflex is not like, you know, I'm thinking that the patient is the gag reflex. I want to do the gag reflex now because the patient is, we're not like the patient is awake. You know, if the patient is like unconscious, then probably I would do the gag reflex. But if the patient is awake, you know, and they still just have the slurred speech. Well, they have the slurred speech, which means they're talking. So they have the slurred speech. I want to go ahead and check the gag reflex. You understand? I want to go ahead and check the gag reflex. Ask the client to smile. Definitely would do that, but that's not that important. And obtain the glucose level. When I get the glucose level, yes, we'll tell if the patient has hypoglycemia or not. But if the patient has a facial droop and the slurred speech, more than like we're thinking along that line of the stroke. You understand? So definitely keeping the client NPO. As I said, gag reflex will probably be the last thing unless the patient is like, you know, comatose or the patient is unconscious. But if they're having slurred speech, they're saying something. So more than likely they're a little bit awake. All right. So Deja means welcome, welcome, welcome. So D is the one that says the risk for aspiration. Keep the patient NPO until the swallow evaluation is done. All right. All right. So which sign indicates severe dehydration in a toddler? All right. So which sign indicates severe dehydration in a toddler? Is it the sunken fontanelle? Is it the dry mucous membrane? Is it lethargy and absent tears? Slight weight loss. Hello, Edward. How are you? Okay, no problem, Dejamin. So which of these indicates severe dehydration in a toddler? Sunken fontanelle, okay. Do we have any other answer? Dry mucous membrane, okay. Do we have any other answer? Read options again. Okay, so Dejamin said read the options again. So it's gonna be the sunken fontanelle, the dry mucous membranes, lethargy, and absent tears, and slight weight loss. So which sign indicates severe dehydration in a toddler? All right, so no tears, dry tears. Hi, Lila B, how are you doing? Welcome. Thank you for tuning in. Geez, I'm about to do mother baby next semester. You will survive, Deja Mins. All right. Talk truth. Welcome, welcome, welcome. How are you? All right. So let's go ahead. All right. So the answer is going to be, let's try to look at the different options we have here. All right. So which sign indicates severe dehydration in a toddler? So all of these are signs of dehydration, but which one of them is the extreme end of it? All right. So sunken fontanelle, that is, it's normal. You'll have the sunken fontanelle, all right, because it's going to take a while before they actually close up. But that doesn't indicate that it is severely, dehydration or severe dehydration going on, all right. Dry mucous membrane, can be mild. Lethargy and absent tears definitely is one that you'd be super, super concerned about. Because especially some time ago and you try to put in an IV on those little kiddos and they don't even move. You're putting in the IV and the hand is like this. They don't do anything. They don't cry, or if they do cry, it's like, and that's it. And it's a big child you're talking about. Slight weight loss. So one of these most, if it's severe, the absent tears, which means that they're so dry that they can't even cry and have any tears coming down. You understand? So anytime you see a child come in and the mother is saying, oh, the baby has been vomiting for days and, they've been pooping for days because they've been having the gastroenteritis and they're having diarrhea and they're feeding them, they're not taking the feed, and the mother says, but when the baby cry, or even when you're there and you realize that the baby is so fussy, but you're not seeing any tears coming from this baby and the baby is crying forever, always think of that. You understand? Think of dehydration because they're not going to be having any tears. You can always go ahead and check their skin. The skin turgor is going to be very poor. You can look at their eyes as well, and their eyes are sunken. They just have this weak look. They just look weak. You understand? The crying and the